Hi, my name is Dr. Brian Everett. I'm an EMS physician and medical director with the UT Health San Antonio Department of Emergency Medicine and the Office of the Medical Director. Thank you for taking a moment to learn about Project AntiSEPTIC, a collaborative effort supported by San Antonio Medical Foundation that involves STRAC, the Department of Emergency Medicine at UT Health San Antonio, the Office of the Medical Director, San Antonio Fire Department, and our area hospital partners. AntiSEPTIC's goal is to improve the early recognition and treatment of septic patients in the pre-hospital setting to help you complete your SEP1 bundle and reduce the mortality of patients with severe or septic shock. Why is it important that we recognize sepsis early and begin treatment? Well, compared to other time-sensitive conditions, sepsis has a very high mortality. Up to 60% of patients in septic shock will die. We can try and reduce that mortality rate by early recognition and early treatment. Now, just like other EMS alerts, a sepsis alert is there to reduce mortality and notify the hospital of a time-sensitive condition. Traditionally, we have the trauma alert, the heart alert, and the stroke alert. Sepsis alert should trigger similar responses in your hospital. These patients are extremely sick and have high mortality and need early treatment. However, there is a difference between EMS sepsis alert and other EMS alerts. Unlike other alerts, it tends to be more specific. We're looking for a particular type of septic patient that would benefit from early treatment. So when you hear an EMS sepsis alert, you need to start thinking severe sepsis or septic shock. We are looking for those patients that are likely to have these two conditions based off the set of vitals that we're gathering. So what makes up an EMS sepsis alert? First, we must suspect an infection. And we need two of the following vital signs. These include an altered mental status, a heart rate greater than 90, respiratory rate greater than 20, or hypotension. We also require an end-tidal CO2 of less than 25. This suggests that the patient has a lactic greater than 4. This also increases our sensitivity and specificity for mortality and severe sepsis by adding in the end-tidal CO2. So remember, our EMS sepsis alert has specificity for severe sepsis and septic shock. So we've had the sepsis alert in the EMS protocols for a while now, and we're starting to look at how specific we actually are at diagnosing sepsis pre-hospital. And I'm happy to say that 72% of our patients that we call a sepsis alert on are diagnosed with sepsis during their hospital stay. 100% of patients received antibiotics in the emergency room. Now, what do you do when you receive a patient from EMS with a sepsis alert? Please remember to fill out the MIST form because there's vital information that your sepsis coordinators will need. First, you need to note the time that the sepsis alert was called. Then we need to document that fluids were given and if antibiotics were administered. We will discuss what antibiotics typically are used by EMS, and we'll talk about how this affects your need for blood cultures. Please note the total amount of fluids that were given and the stop time. This can be used to meet CMS requirements for fluid resuscitation in the severe sepsis patient. Your sepsis coordinators can direct you on where this needs to be documented in the patient's chart. So not only are we identifying patients that are sepsis and we're notifying the hospital, but we are going to start treatments prior to arrival. We give antibiotics to reduce mortality. There's also the significant benefit of having reduced ICU lengths of stay by treating patients early. In more than one study, pre-hospital antibiotics have been shown to reduce mortality, especially in the severe and septic shock patient. So what antibiotic do we want to use in the pre-hospital setting? We want something that's broad coverage and covers both gram-negative and gram-positives. It could be used for urosepsis, pneumonia, or meningitis. It needs to be cost-effective, easy to give, and universally accepted. Most agencies have decided to go with Forcephin and typically give about 2 grams. Some agencies may carry cefepime. Generally, most agencies do not carry MRSA coverage. What about blood cultures? If EMS treats the patient with antibiotics before blood cultures are obtained, won't life fall out? It's first important to consider the patient-centered impact that this has. Mortality is not infected by identifying the effective pathogen. In fact, about 2/3 of the patients we call a sepsis alert on never grow an effective pathogen during their hospital stay. So what does CMS say about collection of blood cultures after antibiotics? There is a carve out for antibiotics given prior to arrival at the hospital within 24 hours of the severe sepsis being identified. In other words, you will not have a fallout if pre-hospital antibiotics are given before blood cultures. However, it is our recommendation that blood cultures are obtained as there may be a pathogen that is not susceptible to recephin. Other treatments that we tend to start include fluid resuscitation. We also use pre-hospital pressor support. The two main pressors used today are push-dose epinephrine and norepi drips. Medics can give push-dose pressors with epinephrine of a dose of 5 to 20 micrograms every 3 to 5 minutes to maintain a MAP goal of 65. By doing this, we reduce the 30-day mortality of these patients. I want to thank you for taking a moment to learn about the EMS Sepsis Alert. You are a critical team player into helping us reduce the mortality and morbidity of severe and septic shock. We need to recognize that these patients are extremely sick and have high mortality. Early treatment and early recognition will save lives. Thank you again for listening. And if you have any questions, you can email me at Everett, EVERITT, at utusca, uthscsa.edu.